There are two umbrella terms of research that are thrown about loosely, and it's so important to understand research methodologies, methods, and techniques in depth if you want to correctly use studies to back you up. So let's look at these two broad terms of qualitative and quantitative. Qual experience, quant numbers, right? That's the easy way to think about it. But what is so often overlooked is the significant differences within these categories. So this is where it gets interesting. A New Zealand study by Timothy Graham and Levac in 2016 explored embodied experiences of people that had sustained a stroke. Just 7 people were included in the study, but the purpose was to gain an in-depth understanding of experiences to inform physical-based therapies for this population. This tends to be where the discussion of such a paper stops. What more do we need to know, right? But we need to understand the methodology, not method, behind this sort of paper. Why did the authors ask this question? What was it that they were hoping to find out? O'Callaghan gives a succinct description of methods, the techniques and processes for gathering and analysing data, and methodology, the way we think about and study the social world. The methodology Timothy and colleagues employed was constructivism, an approach that assumes knowledge is only found in the interaction of people with the world. We cannot extract human experience when seeking knowledge. Rather, we require it. This is absolutely what we encounter within music therapy, where music is a product of collaboration and the therapeutic benefits a cooperative experience. While the paper by Timothy and colleagues is not music therapy research, it is a good example of qualitative research in the field around which the rest of the papers examined are based: stroke rehabilitation. What Timothy and colleagues found was that the relationship individuals have with their body after a stroke is fluid and varied. The body in which they had occupied without disruption for many years was thereafter described by the participants as strange, foreign, unpredictable, and effortful. These terms were grouped under the thematic title as divergent self-body image. Other participants described a more cohesive body self-image, where they were rediscovering their bodies. Descriptions of regaining control and freedom of their bodies were grouped in this thematic label. The authors found that in a cohesive body self-image, participants described anchors of knowledge, a positive attitude, and a supportive environment as fostering a new cohesive body self-image. For the purpose of this oral presentation, what we can take away from this study is the idea that we need to look beyond the medicalised body image of an individual who has had a stroke, because in fact they are not just experience frustration or grief over loss of function, but these people need to be supported to reconsolidate their sense of self-body image. In the process of music therapy, we can explore new ways about thinking about the body, like the sounds we can co-create and the increased spatial awareness of foreign limbs, for example. Now for some quantitative studies. A 2012 Korean study by Jun, Ro, and Kim measured physiological and psychological effects of a movement-based therapy with a convenient sample of 30 patients, post-stroke on a hospital ward. A quasi-experimental design was used. 15 participants were in the experimental group and the other half in the control group. The study was outcome-based, so it was seeking increases in a physical range of movement and increase in positive mood. Physical measures were range of motion and muscle strength tests, both standard measures used by the physiotherapists at the facility. Mood was measured with the accessible Profile of Mood States, POMS, and the more detailed Centre for Epidemiologic Studies Depression Scale, CESD. When testing for homogeneity of the two groups, that is, establishing the two groups did not significantly differ on measures before the study even began, they only found a significant difference in levels of depression, which were higher in the control group. In the results, statistically significant increases between groups were found in the range of movement measure and the mood measure, not depression though. The study was particularly useful in its description of the procedures for the experimental group. For other researchers looking to replicate the study, the procedure was very clear, but it was not so clear what the control group were receiving as their treatment as usual. Comorbidity of depression with stroke is a serious identified problem, and it was not clear whether this was addressed in the control group at all. In fact, the still poor measures of mood and depression in the control group raises that question: what does treatment as usual look like in this area? Will more research into this area ensure stroke patients receive both physical and physiological care in the acute post-stroke phase? Perhaps to encourage this, the authors also chose to include the following statements. Verbal expression by participants about MMT suggested that they enjoyed the MMT, particularly music therapy, and it was encouraging to note the progress and improvement made by participants over the course of 8 weeks of MMT. These are highly emotive comments that are essentially adding colour to the results of the data, but for the nursing staff for whom the authors were hoping to adopt these strategies, it may also be the sales pitch behind the statistics that demonstrate its value. This paper was chosen to highlight an acceptable research design using a population that other researchers or clinicians might also have access to. It's not overly complex in its statistical underpinnings and provides good rationales behind the design. It was also chosen to demonstrate how tempting it must be as a researcher to include personal observations and impressions of the study, as though the data cannot speak for itself. The objectivist methodology of this type of study, one in which measured outcomes are the sources of knowledge of the phenomenon, does not require such personal reflections if the data has shown the hypothesized results. Yet many quantitative papers will also include these comments, especially when they have been grounded in personal clinical practice. Another quantitative paper I have chosen to review is a 2016 German single-blind RCT by Van Vugt and colleagues, which tested the hypothesis that auditory feedback facilitates motor redevelopment in stroke. The novel way in which they tested this hypothesis is most notable in the manipulation of elements of the study. While a convenient sample of people who had sustained a stroke were assigned to an experimental or control condition, such was the design that patients were blinded as to which group they were in. The role of auditory feedback, the authors argue, had not been established as the key reason that gains were made through music therapy. The factors that may affect development were identified as motivation, focusing attention, individual interaction with a therapist, transfer of motor skills, or brain integration of movement-evoked auditory feedback. To isolate this final factor, the authors designed a program delivered on a keyboard that produced instantaneous sound feedback, like a normal keyboard for the control group, and a keyboard that was programmed to vary sound feedback from 100 milliseconds to 600 milliseconds. Any results could then be directly linked as a result of immediate versus delayed auditory feedback, which would null the hypothesis that immediate sensory feedback aids increases in fine motor movement. This is exactly what the results found. In both a 9-hole pigeon test and finger tapping measurements, then an in-depth discussion of the problems with music therapy research was included. The authors argued that there are not enough single-blind RCTs to fully establish evidence, which in turn leads to poor evidence for otherwise generally accepted understandings like immediate sensory feedback aids motor redevelopment, when in fact the motor function of both groups improved. Authors suggest that a motivation factor may be more significant, as well as a specific neurological phenomenon that this presentation does not have the scope to explore. This study was chosen in contrast to the previous quantitative study that used clinical outcome measures as evidence, but was unable to fully isolate one mechanism that improved range of movement or patient mood. This is just one interesting discrimination between studies that fall under that quantitative banner. One was based in clinical work and the other included a laboratory component on top of the clinical population sampled. Jun and colleagues acknowledged that their study looked at an overall integration of therapeutic factors, but Van Vugt and colleagues argue that this is just not good enough. Certainly, this kind of study was more time-consuming and may have lacked the creative aspect we associate with music therapy, but this is quantitative research. We have learned that in an objective scientific methodology, knowledge is not found in human interaction. It is void of it. This might seem harsh, but the key thing we can take away from this study is that we can now look at other factors within the therapeutic setting as being more important to fine-tune than sensory feedback, as it appears this needn't be instantaneous to have a positive effect. Additionally, the study by Van Vugt and colleagues was included in a systematic review and meta-analysis conducted by Zhang et al. That sought evidence for music-supported therapy in stroke-induced dysfunction. Note, this is not looking at psychological dysfunctions like depression, etc. Evidence was found and presented with the relevant tests for comparability in different studies, finding that interventions using music-supported therapy provided, albeit in varying degrees, beneficial effects. Adding to the rigour of this analysis was the inclusion of only RCTs, 7, controlled clinical trials, 2, and randomised crossover trials, 1. The scope of this presentation does not allow for an in-depth discussion of all the aspects of this study, so let's just jump straight to the strengths and weaknesses. This review was based on a similar premise as that of Van Vugt and colleagues, that there are interacting variables that are generally understood to promote motor function and quality of life in stroke patients, but they also wanted to only pinpoint motor function. The use of established clinical assessments ensured the authors could reliably compare the studies. It is interesting, though, that when I was choosing a meta-analysis to review, one from the Cochrane Library written by prominent Australian music therapists and researchers on a similar topic, rehab in brain injuries, pretty broad, I found little overlap in their identified studies. Surely, if both claimed that they had completed an exhaustive search of online literature, they should have some of the same literature. The authors do acknowledge, however, that while the search for this particular study was comprehensive, it would be impossible to include all knowledge available. In addition to this, the authors also acknowledge that only studies with positive results were included in the meta-analysis. There may undoubtedly be studies without positive results that never even made it to publication, and just as many with negative results that were published, but not part of the scope of this particular meta-analysis. What we have learned is to be critical of the literature. Ask the questions that have not been addressed. Think big picture. Think small. There are so many aspects to research that make it complex and exciting, but we need to be able to use it effectively as a tool in informing our practice.